When you really look at the statistics in terms of, when bad things happen, more than half of maternal deaths actually take place after the baby is born in the first 6 weeks postpartum and kind of continuing into a year, right? And so to see people once at the 6-week point is completely insufficient. And about 30% of, maternal mortality events happen during pregnancy, which in a weird way makes labor and delivery the safest part of the entire experience. And that's the thing that most people are generally freaking about.
Yeah, that's true. When I think about all the, maybe a horror story of worst case scenario, that's it.
Yeah.
It's a complication during that process.
Yeah, exactly. So what that kind of translates into is on the one hand, we don't have enough care, because it is, you just have these big gaping holes, in between visits, which is when most pregnancy is really happening over that 46-week journey from when you first conceive to when you're last seen at your 6-week postpartum visit. And, there's just kind of gaps in care that can happen between visits. And then that postpartum period, which is when things really go wrong, you have a single visit, and so it is pretty relatively incomplete in terms of what people are looking for, but it is, kind of this sort of discontinuous and reactive approach, does kind of create the outcomes that we sort of talked about.
Welcome to The Peel, where we explore the world's greatest startup stories. I'm your host, Turner Novak, founder of Banana Capital, the venture capital firm with no gaps in care. What follows is a conversation with Anu Sharma, co-founder and CEO of Millie. I invested in Millie 2 years ago, and it's been fun having a front row seat as she builds a company from the ground up to reinvent maternity care. We hit on all the problems in maternity care, which if you're unacquainted, that means having a baby. We also hit on all things healthcare, like why consumers don't act like consumers, how bundled care unlocks personalization, the importance of picking markets, insurance reimbursement, how Anu fundraised without a product, and the future of in-person versus hybrid versus virtual healthcare. If you're interested in learning about the problems in tax and healthcare, this episode's for you. Let's jump in after a quick word from Attio. There's a world where your CRM is powerful, easily configured, and deeply intuitive. Attio makes it a reality. Attio is a CRM built specifically for today's modern company. It's flexible, easily configures to your unique data structures, and works for any go-to-market motion, from self-serve to sales-led. It automatically enriches your contacts, syncs your email and calendar, lets you create powerful reports, and quickly build Zapier-style automations. The next era of companies deserves more than a one-size-fits-all CRM with outdated UX. Someone recently described Attio to me as the linear of CRMs, which if you're in the know, that is high praise. Join 11 Labs, Replicate, Modal, and more. Try Attio instantly at attio.com, that's attio.com, or tap the link in the show notes and scale your company to the next level. Anu, welcome to the show.
Thank you. It's good to be here.
Yeah, I'm excited to have you. I'm really excited about the problem that you're working on. Can you just kind of talk through what it is, the state of everything that's going on, and then we can go from there?
Yeah. So I'm the founder of a company called Millie, and Millie is a company in the maternal health space. The basic problem that we're sort of solving is the fact that maternity care in America is very broken. It is a massive industry. We spend about $50 billion a year on maternal health. And when you kind of add in wraparound care and kind of adjacent gynecology care that women get as they move through this journey, it's even bigger, maybe closer to $60 to $75 billion a year. But the model hasn't changed since World War II, which is kind of mind-blowing. That was over almost 100 years ago.
Yeah. Why hasn't it changed?
It's basically, at some point, we kind of decided that the right way to do maternal health in general was to kind of just basically create a series of visits that happen at pre-specified points along the way. And the goal of those visits is to kind of make sure everything is going well clinically. And we kind of haven't really moved from that. And the innovations that we've kind of seen along the way have really been around how do we, help people manage pain, during labor. But fundamentally, we haven't really changed, what care is about. And the thing that is kind of crazy is that when you really look at the problem through the lens of a patient, you go through maternity for the first time. It's one of the most significant things that has happened to you in life.
It's like a 2-year process almost, beginning to end and post, and then you're a parent, and it's like another 18 or 100 years.
Yeah,
right?
Exactly. And so, it's a pretty significant life event, as for all the reasons you mentioned. It's also, for most people, really their first significant healthcare experience, right? And
Really?
so, prior to that, maybe you've gone to the doctor, you've kind of, maybe sort of had an annual exam, things like that, but really, I mean, your first real interaction with the healthcare system often, if you're a woman, tends to be your maternity journey. And what the sort of, from a patient perspective, what you're really looking for is, yes, you want great clinical care. You want to make sure that, you're well taken care of. You want to make sure that the baby is born safely and that, everyone comes home and is thriving and doing well. But you're also looking for, a lot of information and education, just in terms of how to take care of yourself, how to prepare for life with a baby. You have questions around nutrition. You're often kind of, it's an anxious time. You're looking for mental health. And then once the baby arrives, maybe you're looking for, support around, really navigating those early days with a newborn, lactation, things like that. But none of that is really part of, the standard maternity care experience, right? It is a very narrowly kind of cast around, let's deliver this baby safely and let's send you home, right? And so it's all about your labs, your scans, and, kind of routine monitoring. And so what happens is that you kind of have this overly medicalized experience in some ways, which is very clinically oriented. And it's completely missing, things that people are actually looking for in terms of the education, the emotional support, the wraparound care. And it's crickets. Like once the baby arrives, it's like, all right, we'll see you in 6 weeks once, and then like send you on your way. And you're like, hey, this is when I kind of like need things, right? And so, so that is, I think from a patient experience perspective, very dissatisfying. But the other thing is, with the way we do maternal health in the US, we leave behind a lot of gaps in care. And so we have some of the worst outcomes of any peer nation.
What does that mean, an outcome?
So what that means is, kind of rates of maternal mortality, near misses, preterm births, NICU stays, C-section rates, pretty bad things happen, right? And so, and that's kind of, pretty crazy, right? For a country that spends as much as it does on maternal health to have outcomes like that, with the terrible patient experience that I just kind of described, that really kind of, does not center the mother, that's kind of going through this journey and her needs, but is very much about, just the narrow kind of clinical care. And even that, it doesn't do well, right? And so the problem we're really solving, at Millie is really rethinking this experience, from the ground up, both in terms of, how do we really create an experience that is patient-centered, but also how do we, do this in a way so that care is more complete, more proactive, more right-sized, and we create better outcomes, which ultimately lower the cost of care. So that's really kind of in a nutshell the problem space. It's big, it's significant, it really affects people. And if you can do it well, you can make a real difference.
Yeah, and I think you've mentioned before, it hasn't really changed the current system since basically World War II, almost 100 years ago. How does it usually start, right? You get pregnant and then just typically, if you're not a Millie patient, what usually happens after that, after you find out you're pregnant?
Yeah. So it's like, all right, well, and people come to pregnancy in a lot of different ways, right? I mean, for some people, they start trying and it's easy. And for some people, they may go through a long fertility journey. Some people may have miscarriages, along the way. And it's not at all uncommon. I mean, that's, I think, one of the more significant things to kind of note. Like, we know about 20 to 30% of pregnancies will end in miscarriage. We know 80% of that will happen in the first trimester, right? And yet, kind of knowing that and also knowing that, we have things like ectopic pregnancies and other things which can be very significant and even fatal. Like, care really begins at the earliest at 8 weeks, and that's because it's the earliest you can really confirm a pregnancy on an ultrasound with a fetal heartbeat. And so the general assumption is prior to that, people don't need care, right? And so I'm like, actually, they kind of do, because a lot of this stuff is, could be happening, in terms of managing miscarriages or, kind of solving for things like ectopic pregnancy.
So if I'm 4 weeks pregnant and I, call or go to the hospital, they're like, okay, cool, but come back in 4 weeks?
Basically, yes.
Wow.
Yeah. So, it's like no one's ready to kind of see you. And, because we've had significant provider shortages and access issues, people can often, like, I wasn't seen until like week 12, right? And week 13 is the end of your first trimester. And I'm like, wait,
that's crazy.
And I'd gone through a pretty long, kind of fertility journey and was very anxious. Like, I was like, oh my God, is everything okay? Is this, is this going to work out or not? And I was 39. So this wasn't like I had like all of, time, right? Kind of like to do this over again. And so, so care it sort of begins at kind of 8 weeks at the earliest. Usually people don't get an appointment until, kind of several weeks after that.
You're a third of the way through the pregnancy.
You're a third of the way through the pregnancy, right? Wow. And so, So that's kind of when it begins, and, just the gaps that are kind of left in that early period. And then kind of thereafter, it's like, okay, we're just going to march you through the series of visits that we've kind of got pre-planned, like, in your first and second and your third trimester. And then it's like, okay, you have a baby.
And it's kind of like every couple weeks, and it kind of gets a little quicker as you get closer, but it's still not that much.
Yeah. So the American College of OBGYNs recommends, somewhere between 12 and 14 visits. But in reality, people can have anything from like 8 to 14. Like, it depends on when their care began and, like, how often, their provider decided to kind of see them. And so, yeah, I mean, it's relatively few touch points, right? And the crazy thing is all of these touch points really happen during pregnancy for the most part, right? So you'll be seeing, like, whatever, like, if you follow the 12 to 14 week cadence, most of those visits, really happen during pregnancy. And you are generally seen once at the 6-week postpartum point after the baby arrives, right? Which is mind blowing, because when you really look at the statistics in terms of, when bad things happen, more than half of maternal deaths actually take place after the baby is born.
Really?
In the first 6 weeks postpartum and kind of continuing into a year, right? And so to see people once at the 6-week point is completely insufficient, and about 30% of pregnancy of maternal mortality events happen during pregnancy, which in a weird way makes labor and delivery the safest part of the entire experience. And that's the thing that most people are, like, generally freaking about.
Yeah, that's true. When I think about, like, all the, maybe like a horror story of, like, worst case scenario, that's it.
Yeah.
It's like a complication during that process.
Yeah, exactly. And so, so what that kind of translates into is, like, on the one hand, we don't have enough care, because it is, you just have these big gaping holes, in between visits, which is when most pregnancy is really happening over that 46-week journey, from when you first conceive to, like, when you're last seen at your 6-week postpartum visit, and so, there's just kind of gaps in care that can happen between visits. And you have uninformed patients who may have never been through this before and who can't quite tell the difference between, like, is this clinically significant or is this not? Like, and they're kind of counting on their doctor to be able to kind of, like, make sure that they're getting seen when they need to be seen. And then that postpartum period, which is when things really go wrong, you have a single visit, and so it is pretty, I would say, kind of, I mean, we already sort of talked about, how one-dimensional care is and, relatively incomplete in terms of what people are looking for. But it is, kind of this sort of discontinuous and reactive approach, does kind of create the outcomes that we sort of talked about.
Yeah. Do you know why it hasn't really changed? Like, because the more, like, when I learned about, so our experience having a kid, like, it was like every month in the beginning, we'd go see someone, we'd sit in the waiting room for 30 minutes. And we'd see the doctor for like 10. And it was, I don't know, I'd almost say it's like inhumane. I don't know if that's the right word, but it was like not the best experience when you're going through a massive life event. Like, for a lot of parents, it's like one of the most significant processes or moments in their entire life. So do you know why it just never really changed?
It hasn't really changed, for a couple of reasons. I think one, everything we do in America when it comes to healthcare is driven by reimbursement, right? Which is like, okay, what does insurance pay for, right? And insurance pays for, like, X number of visits, right? And that rubric really hasn't evolved, right? And so in more recent years, research is being done around the fact that, like, let's actually objectively look at what's going on in terms of, pregnancy and what people actually need, right? And so if you really look at it on, like, two axes, like, on the one hand, just objectively what people need from a clinical care perspective, what you'll find is about 70 or 80% of pregnancies are actually objectively low risk, and maybe another 10 to 15% are moderate risk, and 5%, maybe up to 7% are high risk, which means people do need different levels of kind of clinical care in terms of the cadence of their visits and what the content of those visits should be, as well as, kind of the level of monitoring that they actually require. So a one-size-fits-all approach really doesn't make any sense, objectively from a clinical standpoint.
But it's probably the most cost-efficient way of doing it.
It's the simplest way from a reimbursement perspective. It's like, on the average, people need X number of visits. They happen, like, at these points. This should catch, 80% of everything. And so, a lot of American healthcare is built on these averages, right? As opposed to kind of really the personalization, and maternity is not just the case in point. Like, if you look at cancer care, for instance, right, there's a general recommendation, you're 40, now you need a mammogram or like XYZ. That's based on average distribution of risk, right? But if you really look at individual family histories and, things like that, some people will probably never get cancer. Some people will probably have a higher disposition towards getting cancer, right? And so they need a different level of screening and frequency. So in general, I would say there's a lot of one size fits all care in America, and it's driven by how reimbursement is generally structured, And so that's one piece. And then I think kind of the other side of it is, studies also show like people need different levels of, kind of support, right? Supportive care, right? And so supportive care is things like, kind of mental health or, nutrition care or social support or whatever. There's a lot of conversation around social determinants of health, and that's just like not part of the healthcare equation. Like, we look at healthcare very much in terms of like the sick care, like side of healthcare, as opposed to like, what do we really need to make sure that someone is well taken care of in terms of their overall well-being as they move through this journey, right? And so I think that's the other side of how reimbursement is kind of structured. It's not designed to be holistic or preventative. Like, it's really designed to kind of make sure that, we're kind of like doing whatever the clinical, like sort of management of something needs to be from a sick care management perspective to prevent bad things from happening. And we do it in the most one size fits all way possible.
Yeah, it's almost like anytime we need a like an intervention or like some kind of like medical, like moment or intervention, that's the thing that really drives it all versus being preventative. Like with preventative, it's like, oh, this person drinks water and runs a lot and does all these healthy behaviors and it doesn't matter.
Yeah.
Like they don't get any benefit from that.
Yeah, and they don't. And it could be somebody that does all of those things, but has a family history of cancer. And so they're probably still going to be screwed, right? Like some.
Yeah.
So, they need fair. Still like a higher level of monitoring, even if they have a healthy lifestyle, right? And so that kind of personalization for like, what is it that somebody really needs, to be in optimal health is just not part of how we think about American healthcare. And the nice thing is like in the maternal health space, as you know, I've been in healthcare a long time. Like, it's been almost 20 years. Like, I've seen a lot along the way. But it's really the first time in the maternal health space that I was kind of drawn to this problem because we moved to kind of effectively a bundle payment model, for reimbursements, which is basically, here's like what you're going to get in terms of dollars, right? So long as you meet certain kind of, check boxes, you can design care inside of that the way that you want, right? And so that's kind of it gives us the freedom to basically kind of like clean sheet this and really think about, okay, how do we, kind of create a healthcare experience, which is designed with the patient and their needs in mind and really right size care, based on, kind of what their sort of level of risk and level of need is in terms of the care team composition, and then personalize that further in terms of the frequency of monitoring, the type of monitoring, the information we want to kind of, put in their hands to be able to help them kind of navigate that journey alongside us. And to just really kind of, approach it in much more of a, personalized and right-sized way.
Yeah. So, I mean, it'd be an interesting segue then to more nuance around what Millie is and how you're personalizing, how you're giving the exact care team that someone needs. Can you just kind of talk about maybe we start actually the very beginning. What was like the founding story when you first decided this is what I'm going to do?
Yeah. Oh my God. So I had quite a saga. Like, I was one of those people that, there's some people who, kind of look at their life and they're like, the things I want to do in my life are like, I was not one of those people. I was basically like one of those people that kind of had a very nonlinear path to everything that I've kind of ever done. Like, but
it wasn't like you were meandering. Like I know you only had a couple like roles or that you did, but they were very long. Like you spent a lot of time working on the problems that you were working on.
Yes, that is true. So my original goal in life, however, was to be a fiction writer, which my parents shut down very quickly.
Okay, I did not know that.
They were like, no, that can be a hobby.
Was there any discussion? Like what kind of fiction did you want to do?
I love travel, I love, so I mean, my ideal job would have been, okay, so even before that, like I would have loved to have been a natural historian or like, kind of, I was very inspired when I was a kid by the stories of a guy called Gerald Durrell, who was kind of, the sort of British conservationist, who had a very kind of non-traditional sort of like family life in his, mother moved him and his siblings, to a small Greek island, and he kind of like free roamed and like collected like sort of, kind of zoological samples,
Okay.
all over the place. And then it found himself like a guy who was sort of a quirky dude who lived on the island, who then sort of taught him a lot about like nature and biology. And I was like, oh, this sounds like a pretty awesome way to kind of like,
Just be an
live.
island biologist, kind of just roam around. Yeah.
Yeah, no, totally. And I was like, that sounds pretty fun. And so I was like, actively like thinking about doing kind of natural history and learning about, kind of conservation, the environment and such. And so, and then that kind of, opened up sort of just generally sort of like, the idea around like, just travel. And I traveled fairly extensively and, was lucky enough to have those experiences. And I was like, I love writing and like, kind of, really thinking about kind of, travel and context, of writing, it was sort of a very kind of evolving path. But my parents were like, no, you need to get yourself a real job. Like, and so I got a degree in economics and then fast followed by, an MBA. And, before I knew it, I was a management consultant. Right.
Okay. Well, I mean, I feel like that's kind of a common path for people though.
It is a common path.
It's like, hey, you need a job.
Yeah, exactly. And it's kind of like an ideal job for someone who doesn't really know what they want to do because you can work on an assortment of problems, right? And so, and I did. Like,
yeah, you did it for like 8 years too.
Yeah, I did. And I worked on a really sort of like, wide variety of things before I kind of like fell into healthcare, like, and healthcare just became like a very endlessly fascinating place because it's like, it's a massive industry. Like, it's whatever, it's the biggest piece of the US GDP.
Yeah, it's like 20% of GDP, something like that.
And it's not one industry. Like you've got, kind of the health insurance side of the industry, you've got the care delivery side of the industry, you've got like pharmacies and PBMs and drug development and life sciences and sort of that whole thing. You've got devices, and there's a whole bunch of stuff that's happening in consumer health around wellness and prevention, which is sort of like a crossover like thing. So, and then you sort of look at, just how broken American healthcare kind of is and all the different, ways in which you can kind of innovate, at every level, right? And so for somebody who doesn't really know what they want to do, you have like a lot of problems that you can sort of solve, right? And that was my original draw into it. And then I basically, kind of, was doing a lot of that work in the years leading up to the Affordable Care Act and then the other side of it, which was a time of a lot of change in the industry. And so I worked on, kind of the early sort of, exchanges and how to expand access, to more people. So whatever we all kind of remember as like Obamacare, like, and like opening up access. I did a lot of work around value-based care and bundle payments and, different ways in which we can kind of pay for healthcare and who owns that risk and how do we kind of create better alignment. I did a lot of work in M&A, and that was sort of my background. I was kind of like, just trucking along. And then I was like, I don't really want to spend 4 days of my life traveling every week. And I took a sabbatical year, came to Stanford, spent time, just really immersing in the world of data and technology and all the ways that, we could apply some of that thinking into healthcare, to create better, just sort of better care experiences for people.
Yeah. What was your biggest takeaway?
I think the biggest takeaway I had at that time was there were a lot of people in tech who were like trying to like hack healthcare. And I was like,
healthcare, okay.
And I was like, no,
it sounds like, yeah,
it doesn't work like that, right? It's a very complicated industry, and you have to be very surgical in how you think about innovation in that industry because you will get beaten up, right? Basically, and so you have to kind of, really think about, okay, how does this industry work? Where are the incentives? And then how do I build something that's actually going to fit? And is the moment right? And
so that was kind of the biggest takeaways from
that really was the biggest takeaway, from like watching just, so many kind of like early digital health companies just like fall into the graveyard. Like, it was just sort of like, okay, that was a mistake. Yes, technology and data have a lot of like, kind of application in healthcare, but you have to be very intentional about where you apply it, and just really kind of be very thoughtful about like where the spaces are right for innovation. And so that was my big takeaway from the consulting years. And I spent time, building a company alongside the former CEO of Safeway in the employer health space, which was pretty hot at that time. And I learned a lot there, over 6 years around how do you really build things from the ground up in healthcare and get them adopted by members and paid for by the mainstream system, right? And we worked through a lot of different spaces of healthcare. And so I learned about, kind of this innovation within kind of like pharmacy and drug costs and, how do we move care into the right settings? How do we really incentivize, consumers to act like consumers when it comes to healthcare and really, kind of use their benefit plan?
Do consumers not act like consumers usually?
No, consumers do not act like consumers in healthcare.
Really? Well, how do they act?
Well, so the way that you pay for healthcare is, you basically have some theoretical number, which is what something actually costs. The thing that you pay for is your deductible and your copay. You kind of sort of, are flying blind, in terms of, is this a high quality provider, or like, is this where I'm going to get the best, like, bang for my buck? You don't really have that information the way that you have it. It's sort of generally like, okay, well, I have a problem. What's the closest place I can go that has an appointment, right? And then you just sort of like do the calculus. Okay, is this in network with my insurance? And then fine, it's in network and I'm just going to go there.
Yeah, you just kind of take whatever the rails are that your employer
Yeah.
or whoever the health
Yeah.
provider insurance that you're
Yeah.
using. Yeah.
And it may be shocking to know that if you got like a basic like lab draw at like, Quest or LabCorp, versus going to a hospital, there is a tenfold cost difference there. Like, most people don't think about that, and so we're not used to thinking like consumers in healthcare, and really shopping, for where you're going to get the best, experience, at the best value. You just kind of go like, and so there is actually a lot of interesting work that was done, to kind of really help people, kind of think about preventative care and, really apply that type of consumer thinking around taking care of themselves and also getting care in places that made sense for them and the employer. So I learned a lot, I would say, like in the bird health years around, how do you really innovate in healthcare? And we made a number of mistakes around like, places that you should probably not innovate because
really?
you're just going to get beaten up.
What were the biggest mistakes there or biggest learnings?
I think the biggest thing was like healthcare can often be a game of scale, and so if you've got, so either you pick white spaces where you can actually go build something and the conditions are ripe and you can actually create something of scale, or you have to have scale in order to go get the healthcare system to bend in the direction you want it to. And I think one of the bigger learnings of Safeway was that, Safeway had 300,000, covered lives between the members and dependents that were on their plans. And they could sort of, work with their like, insurance carrier, in this case, Cigna, to do a lot of things, because Cigna cared about that business, But if you're like, a small company with like 500 people, they're not going to change anything for you, right?
Yeah. They're like lost.
Yeah, exactly. And so, so scale matters in healthcare. Like, if you aren't like innovating in, some important, like some spaces that are like already kind of pre-built to innovate in. So picking your surface area is possibly the single most important thing in terms of your determinant of success.
Really? So then what would be, you talked about there's areas that are better to do that in. What are some examples of good spaces? And hopefully Millie's one of those as an investor in the company. What do you kind of think through?
So, I mean, I think, back to, what we were really chatting about. I mean, I think what drew me, I mean, given all of my battle scars in healthcare and the work that I kind of done, learning about like, okay, what not to do and the things you can do and probably get away with, was, that I noticed in the maternal health space, like, we've moved to bundle payments, right? And so now suddenly you have a lot more freedom to kind of design a care model and a patient experience to go along with that care model because you have a finite and predictable amount of dollars, that you're going to get.
So bundled care, that is basically when you have a certain medical insurance code, there's a certain thing that's attached to that you have to provide to someone. But by putting multiple codes together, you can, is that, am I on the right track with that? Or?
The right tracks. But basically, like, there's two ways in which healthcare gets paid for. Like, one is you go to a visit and you kind of get paid, like the doctor gets paid to do that visit. That's called fee for service. You get services, you get paid in fees, right? Like, so bundle payment is like you look across an entire episode of care and you say, this is a flat amount you're going to get, right? And so so at that point, you're still paying your copays and deductibles, but like, I have certainty of like, what is the reimbursement I'm going to get, right? And I can kind of design sort of design the care and the experience and like the technique, whatever you want to do to kind of like improve the efficiencies and, of how you do that in terms of like the design of your technology enablement and whatnot, like, that sits underneath that.
But then you also know what kind of costs you can afford to have because you have the defined revenue that comes in.
Exactly. So it's like, here are some fixed dollars, like, not make it happen, right? Which is a very different thing than I have to follow this path in order to get the total reimbursement that I am expecting because I'm now wedded to this sequence of visits, right? And so that's what used to happen. And so you couldn't break out of that, like, it's like X number of visits that kind of like make up maternity care. And now you have to do those visits, because you have no choice because that's how reimbursement works. And so instead, if you kind of clean sheet that and say, here is a total number of like dollars that are, available to you for providing care over this episode, suddenly it's like, okay, well, I can work with that, and see what to do.
So then, if I'm just kind of guessing here, the way that kind of works with Millie is, I think you've mentioned certain people need more care, certain people need less. You can kind of flex the capacity utilization of the
Yeah,
care you're
you can,
providing.
and who's providing that care, right? And so we know that 70 to 80% of pregnancies are low risk, right? And we know, 10 to 15% are going to be moderate risk, and we know the rest are going to be high risk, right? You can say, okay, I'm going to bill for the 90% of pregnancies that are low to moderate risk, and say, okay, if that's sort of what I'm going to do, I'm going to lead with midwifery care because midwives have been proven to create better outcomes, for low risk pregnancies, you know, compared to an OBGYN, right? And so you can kind of right size the care team, to fit the risk of the patients that you're actually taking care of, right? So that is one piece. The other thing you can kind of do is to say, okay, if I center the patient in this journey and really think about all of their needs, how do I kind of take the insurance dollars, the HSA and FSA dollars and other dollars that are kind of like available, and then knit them together into kind of one unbroken experience for the patient, to create something that actually makes fundamentally more sense, right? That has been missing all along in terms of, really helping people with information that they need at different stages along the way to make, to take better care of themselves and to make the decisions they need to make, as they kind of move through time, to be able to kind of look out for risks that, they may be exposed to at different points along the journey, that are stage relevant and personalized to them, and to kind of like communicate with their care team so that we can do early detection and better management of risk, between visits, during that episode. And then how do we redesign postpartum care so that we can actually take advantage of the fact that, we now, don't have to kind of, be wedded to a certain schedule of visits. So we can do a home visit, right? And we can kind of, go and see patients and babies and kind of see how people are doing and kind of make the appropriate care pathways as opposed to like, I'll see you once at the 6-week point, kind of a thing. So you can kind of design care in a way that is different, right? And you can kind of, power that with technology, and you can pull pieces together, so that it is, more complete, more proactive, and more right-sized, in the end, and also more personalized, right? And so, so those are the things that, we do at Millie, to create a very different care experience than what people are kind of used to. And then we kind of, do some things which are kind of unique to us. Like, I mean, we know people need care sometimes before that first, kind of 8-week visit. And so we make ourselves available at that time, right?
Yeah, you do like within the first 24 hours, like next day.
Yeah. So, or within 48 hours or whatever, like, so we always have the ability to kind of create care pathways for patients, who may need to be seen earlier. And so I think it's a fun thing to be doing. And like, back to your original question in terms of, like why maternity care? Like, it's just like, I mean, okay, first of all, it hasn't changed in 75 years. But second of all, like, back to what I said, like, I mean, the conditions are right in the healthcare industry, right? For innovation to actually happen here, unlocked in large part by reimbursement changes, because we can now flexibly design care, but also because, we're kind of in a maternal health crisis in the country.
Really?
And payers meaning insurance companies care a lot, like, about, we have significant OBGYN shortages. They're looking for newer, better models, which incorporate midwives and other types of professionals, which have sort of, every other country does this, like Canada, the UK, France, the Nordic countries, Germany. For some reason, we just don't do it here in the US, and we're like, what? Why don't we do this? Like, so we're kind of, solving for kind of, creating expanded access in the face of, just significant provider shortages. We're looking at ways in which we can kind of create better outcomes and better actuarial value, implement, value-based care. From health systems perspective, similarly, I mean, they're like having a hard time staffing and, keeping things financially afloat in the service line. They're looking to kind of, manage care quality. They want to partner with innovative companies, so that they don't necessarily have to be in the service line themselves. And then patients have changed, I mean, 80% of parents are millennials. Like, have seen things like, One Medical or Kind Body or, other sorts of things. And
like these premium consumer grade healthcare
yeah, or just like less friction in care, like, and they experience that in every other part of their life as consumers. And they've seen that it's possible in healthcare with companies like that. And now it's kind of become the new thing that they expect, right? And also, I mean, I would say, it's worth noting 42% of births in the country are actually paid for by Medicaid.
Interesting. Medicaid is like income threshold level?
It is income threshold level.
Okay.
But in maternal health, they are a very progressive payer. They pay for things that commercial insurance don't, like
really,
like doula coverage, prenatal education, the dyadic management of the mom and baby in that postpartum period, community health workers that can come to your home. So there's a real opportunity even in the Medicaid space, to really take a different, better, innovative care model and really knit it together with the reimbursement structures that are there. And so it's a space we actively look at, and we actually do take care of Medicaid patients even today, and so I think just in general, there's, I think, a lot of white space for innovation, and everyone wants it and the conditions are well aligned and we have the reimbursement structures to do it.
Yeah, so like all the different parties, if you think about it as like a 3, 4, 5-sided marketplace, I don't know how many sides are on this thing, but everyone is incentivized to provide better care in this situation and be open to like even letting that happen.
Yeah.
Because it sounds like historically maybe no one would, like certain sides of the marketplace would just say absolutely not.
Yep. No, exactly. So it's like, so I think those conditions are right. And I think the other thing is like, we spend a lot of time thinking about which markets to be in and which markets not to be in. Right. And so,
you're saying like cities as in markets. Okay.
And I think that's an important thing in healthcare. Like in healthcare, there's a lot, I mean, people think of healthcare as like, oh, it's one big it's a massive industry, it's one big national thing. It's not. It's actually a series of like regional markets, each with their own kind of payer provider dynamics, and it's their own like little like sort of universes.
Like monopoly almost.
Yeah, it's kind of, it's a weird thing. Like, it's like, if you're any other consumer company, like you can be anywhere in the country that you decide to be, based on demographics or whatever it is that you're kind of doing. Like in healthcare, that's not true. In healthcare, you do have to think, kind of pretty hard about not just demographics, but also, kind of the payer landscape and the reimbursement structures. You have to think about, health system partners and, the viability of, who's there and, whether you can partner with them and things like that. So there are other factors you do have to kind of consider in market selection, right? And you can get it very wrong by being in the wrong markets.
Just from how you work with the insurance companies how would you recommend someone who's trying to figure out, I know I need to work with insurance, I'm starting from zero, how do I figure this out? Like what would you tell them to work through?
So there's, I think, kind of like two basic sort of like avenues, right? Like the one avenue is, okay, they're like maternity, like, it's always been a reimbursed thing, it's just not been great.
Okay. Not been great. Like the experience, you mean?
The experience and the outcomes. There's, it's kind of like, so we're not fighting for new codes to exist, right?
Yep.
The codes do exist. And
it's a very large number too.
Yeah.
Like a dollar amount that you can get reimbursed on. Okay.
Yes, it is.
So there's a business opportunity because the revenue, the amounts are there. Yeah.
Yes. I mean, so just thinking purely in terms of like VC terms, like, the LTV is very significant, right? And so, so it's like, okay, great. You've got this like massive market, $50 billion a year plus upside, and you've got underserved patients, you've got the conditions that are right, on the healthcare ecosystem side for payers and health systems. Medicaid itself is a massive, huge opportunity, to tap into, which you can do alongside or different, and the LTV is significant, and if you can kind of, find a way to kind of innovate and come up with something that is a better model that can work on the unit economics and can work in terms of better outcomes and, create good experiences while making all of that work, you've got like a significant business, right? And so, which is, I think, kind of, pretty nice to kind of contemplate in this space. But not every part of healthcare is like that, right? Like, primary care, for instance, like, which has been kind of in the news a lot lately. Primary care is just, it's, a lot of people kind of assume that, oh my God, like, primary care, like everybody needs primary care. It must be a massive market. What people forget.
Everyone gets it. Yeah.
So theoretically, like if you were looking at it just, without knowing anything about the healthcare industry.
You assume that's the biggest TAM.
Yeah,
A
it's like it's
massive
a
market.
massive TAM. Everybody needs this, and we have primary care shortages in the country. There must be tons of latent demand. What people often forget is like your reimbursement is $150 a visit. People might need 2 visits a year, if even, right?
Yeah, I
People are not terribly compliant.
actively don't go to the doctor.
Yeah,
Maybe that's not a good thing to admit.
it is, but it's a very different equation, right? So you're kind of counting on basically people coming to you over a very long period of time to kind of, make that LTV work.
So you're figuring out the churn or the retention. Do we have them for 2 years, 5 years, 20 years? It could be any of those things.
It could be anything, right? And so the economics of a business like that, are very different. And so there was this theory where, just okay, primary, and we saw a lot of primary care companies kind of pop up, right? Led by One Medical back in the day, and then many more kind of followed. I think One Medical built the scale advantage, right? To be able to just they're everywhere. They're sort of ubiquitous. They're not immune from some of the issues in the healthcare industry, but they kind of, built scale and, that made them attractive to employers, who want to actively contract. Carbon Health has kind of, done that as well. Now, different issues, around capital efficiency and things like that, in these spaces, but the economics are very different, right? So yes, on the one hand, there's a lot of need and there's consumers want it, but you have to find that distribution channel, which is going to make it work for you, which in this case happens to be employers, right? But there are lots of other spaces where, they're relatively, I would say, there are relatively few places where you can have this kind of large LTV, which is concentrated in a single episode, in healthcare.
Yeah, and I think you've kind of phrased it before. Maybe it was actually someone else who told me this, but I think it's super, super relevant. You almost have to think about your distribution in healthcare before you even think about your product. Is that a fair way to think about it?
Yes, that is very true.
How would you do that? Is the employer your distribution? Is insurance the distribution in this case?
Yeah, so insurance is the thing that pays for it, right? Alongside the consumer. So it's okay, some combination of your insurance company and the consumer are paying for the thing that you're selling, right?
Yep.
Many employers are self-insured, which make them both a distribution channel as well as the insurance company, right?
Oh yeah.
So, they're kind of a weird one, right?
Are those good people to partner with in this case, or does that make it harder?
I think to partner with employers, you have to have scale, right? If I'm I don't know, let's make it up, big company.
Amazon. Big
right?
Employer, yeah.
Amazon is in the business themselves, but sure.
Okay,
if you
we'll
were
pretend
Amazon,
they're not. Yeah.
we'll pretend they're not in the business.
Maybe that's why they acquired One Medical, because it just made so much sense.
That's a whole other thing. We can talk about that too. But, but basically, if you look at, any company which has national footprint, they're I don't really want to kind of create different benefits in different, parts of the country that I happen to be in. I want one seamless thing, right? And so when you look at, for example, the One Medical, they have that national footprint and it makes sense for them to partner with employers, right? And so you have to kind of think about, is employers a distribution channel I'm kind of going after? If so, then yes, I need to build a national footprint, right? And so it's okay, they basically kind of said we solve for primary care. Now we're going to add pediatrics. We're going to add, other kind of layers of care and just really kind of serve our end customer, in this case, basically an employer, as deeply as we can in as many places as they happen to be, right? And so that's how they've sort of thought about distribution. If you look at Kindbody, for instance, they basically had to build a national network. They, I think, have over 140 partnered sites. I think they own 30 of them, something like that. Right. And so they're expanding and but they have a lot of partner locations, but they had to build that national network to serve the customer they were going after, which is employers too. Right. Mm-hmm. So you do have to kind of think about distribution first because it will heavily affect the thing that you're building. Right. And so in our case, for example, for Millie, we basically are building for, yes, we're direct to consumer and we, kind of are taking care of patients in the end. But we're also kind of very thoughtful about, the fact that, we want to be building in conjunction with health systems, solving a piece of the problem that, health systems are kind of facing, through some level of service line integration. And, we're also interested in Medicaid MCO, right? And so for us, if that's what we're kind of ultimately solving for, then it's choose the markets where those conditions are right and then build density, right? And so And sure, we can opportunistically kind of, layer in virtual care and do things like that. That's certainly an opportunity for us, but you have to kind of think about that, right? And when you do that, you have to think about, okay, like what are the economics of that business, right? What is the reimbursement that I need to solve for, or the partners that I need to solve for, like, and therefore where do I be, right? And how do I design the care model and all the kind of sort of clinical and technical underpinnings of that model to be able to make the economics work for those segments that I'm kind of going after, and so that's important, if you are working in the reimbursed spaces, right? Like, because that is a gating factor. If you're not working in the reimbursed spaces,
so that means no insurance, it's pure cash pay.
It's just pure cash pay. It doesn't matter. You be where you want to be. Like, you be as close to the customer as you want to be. It's just like consumer, right? But for anyone who's thinking with an eye towards insurance in the future, it is important to think about, okay, it's not just like I'm going to build this, there are going to be early adopters, on whom I'm going to prove this out. Then one day I'm going to become in network with an insurance company because they will see the light of day and say, yes, this should have been covered by insurance,
And we'll just switch. We'll just
like kind of give you these codes and, and then off you kind of go. That's much harder to do and, a much, much harder hill to climb. And even if you did it, you could do it for one insurance company, but there's like a cast of hundreds in the country, right? So you sort of do one thing at a time, and so that is a much harder road to take for companies that are building something that does not have existing codes for.
So you would recommend just generally working with insurance to make sure there's reimbursable codes that are commonly used and make sure you just follow all the guidelines on hitting everything for reimbursement for those codes.
Yes. And I think, you can certainly build a cash pay business in healthcare.
Plenty of people have done it.
Plenty of people have done that, but in the main, the biggest piece of the US healthcare system, is reimbursed care, right? And so you're going to be chasing after a much smaller market, for people who can afford to pay large sums of money out of pocket. Maybe there's concierge medicine. People care about experience. They care about, kind of on-demand access and convenience and things like that. But that is a relatively small portion of the market. There is an interesting movement in primary care, which is direct primary care, where it's sort of like it's a whole other thing where doctors like, what, we just are kind of done with the reimbursement system. Like, we're just going to go off, like build our own like sort of practices, and we're just going to basically work directly with patients, and they're going to pay us a membership fee, and we're just going to take care of them. And that's, predictable for us, and it's like a better experience for patients. And I think there is sort of like a growing kind of movement around that. And I think it's quite interesting. But I think the tricky thing about it really is that the way that insurance is recognized, you're still sort of considered to be kind of, in the deductible phase of your plan, when you're in the deductible phase of your plan, right? And direct primary care is not sort of seen the same way as going to another in-network provider.
So it doesn't count for your deductible. So you, as a consumer, if you use an out-of-network primary care, you run the risk of just your healthcare costs costing more to you.
So you just don't have the kind of parity. So it's like, is this recognized as insured care or not? Like, just like,
that's tricky.
So that's a little tricky. So there is a lot of like back and forth, in Washington, D.C. around like, how do we get direct primary care models recognized as a legitimate, not out-of-network, but like in, kind of a, a different type of, kind of reimbursement thing. So there's a lot you kind of have to think about when it comes to distribution. Like, is this for insurance? Is this not for insurance? And if it is for insurance, okay, like, is it employers? Is it like more broadly, like, other payers? Like, and then accordingly, you have to kind of build your economics backwards and then build a product and everything accordingly.
So one thing that I always thought was impressive, and maybe I was part of it. So you raised like a decent amount of money for Millie before you had a product or distribution. I mean, you kind of had to with the type of company you were building.
Yes.
How did you do it?
Oh, God. I think it was, yes, we did raise a significant amount of money on basically a deck and a team. That is true. I think what helped us was it was a great team. So I think there was a lot of credibility that this team could make it happen. And I think we done some of the foundational work. Like, we had a good sense for the care model that we wanted to execute on. We had a good sense for its clinical underpinnings and the fact that, there was kind of enough clinical proof out there for this model, to demonstrate the outcomes. And so really from an investor's perspective, it was execution risk.
Yeah, that's what I kind of felt like too. It felt like you'd solved for a lot of the things other than actually building it, which was like a wild card, right? Like
I was like, can they do it?
Yeah, but I do remember you were like pretty close. Like I just remember you did launch the clinic very quickly after
we did
raising the money. So
we did. And so we done all of the foundational work. And I think that was sort of, basically how we did it and how I would recommend anyone do it. I think the things that, helped us were having a very strong team, that had all the component parts, like we understood the business of healthcare, we understood technology, we understood clinical. We had basically kind of, put the definition around the care model. We knew that clinically it was sound, and we had identified the market we were going to be in. We had identified the health system partner we were going to work with. And, we had line of sight to the insurance contracts, right? So a lot of I think the foundational pieces were there. And then, we got the money and we launched in 3 months, and which, yes, even by traditional standards was pretty impressive. And we did it very cost efficiently, which was also pretty impressive, right? And so I do think it's not, there's this sort of general assumption that, oh my gosh, healthcare services is just stay out of it. It's too complicated, especially if it has 4 walls. And I think it's just not true, right? I mean, it's a massive opportunity. There's lots of white spaces in it. You can certainly build something of huge scale, get it paid for by insurance, and do it fast and do it capital efficiently, right? You just have to kind of pick those spaces, right?
Yeah.
And not overbuild.
Yeah. So I think one last topic we want to hit on was kind of this telehealth, in-person, hybrid. There's kind of a couple different approaches people have taken over the years in trying to solve some of these problems in healthcare. How do you think through in-person, hybrid, entirely online, virtual?
Yeah, I mean, I think you have to really think about the thing that you are built, the thing that you're ultimately building for. I think there's a few things where, a purely virtual model makes perfect sense, right? Which is mental health, for instance, right? Okay. I mean, it's yes, you can establish a long-term relationship with a provider, and you can be seen virtually. There's not a whole lot that you have to be seen in person for, right?
Yeah, it's all just talking, basically.
Yeah, and then that makes sense, right? And I would say certain parts of primary care, where it's you can do sort of an assessment, virtually, and then, prescribe medications or whatever it is. There's a certain category of primary care that kind of fits within that, where you're basically kind of, the value of virtual is convenience, maybe experience, maybe highly specialized understanding of that particular patient population. Folks Health, for example, is a great, they understand the LGBTQIA population. And, they've built some solutions, which are very focused on that population. Works perfectly. Right. And then, there are some things where it's you kind of have to be seen in person. You can't really deliver a baby through an app, right?
Yes. So you've got the phone holding up while she's delivering.
Oh my God. So in-person care is important, right? And true. So I think in that instance, it's but does all care have to be in person? No, we do about 50% of our visits virtually, and you can do that. You can give people connected cuffs and, do it via telehealth, so that helps with access and convenience, but at the same time, when they need to be seen in person, they've got somewhere to go, right?
And you can do that. Technically more capital efficient. It's lower cost to deliver virtual care, just looking at a spreadsheet.
Yes. I mean, it can be, assuming you have a large enough market and large enough LTV.
Yeah.
I think people over-index and overthink that, oh my gosh, if it's capital efficient, it must be more scalable. And that's not always true, and so I think you can legitimately have hybrid models, in spaces like maternal health, where people do need to be seen in person. They do build these long-term relationships with their provider. There's a lot more LTV. There's a lot of LTV in that episode. There's a lot of LTV in continuing care, and where you can build something, very capital efficiently. It does not have to be a high street retail build, which takes you a year and $1 million. You just don't have to do that.
Yeah. How did you get around that with Millie?
We locate ourselves in what we call these jewel box clinics in medical office buildings, where we can create a very elevated experience, but we can also launch in 3 months, at $150K.
Yeah, that's pretty good.
Yeah. And I'm okay, well, I mean, in that case, if it can be done, and if you're picking markets where there's latent demand, and you've got fundamentally sound unit economics, and you're in network with payers, and you've got the right health system partners, you can absolutely do this. So I think people sort of like think in very binaries, like, virtual, capital efficient, and scalable. They forget about LTV and like, all that.
But then also competition too. Like if it's just perfect economics, really high margin, and everyone does it, you spend money elsewhere.
You do. And I think that's happened. Like, I think in a lot of the virtual care models, particularly primary care virtual care models, it's undifferentiated. Like anybody can do it. Like, and so you can build bigger moats, and things like that with these hybrid models where, it may be a little harder to build, but it certainly can be done. And if you can do it, you can build massive businesses, like, where you've got a lot of white space and all the stars aligned, in the healthcare industry.
Yeah. And when you even look at some of just the largest companies in the world, just go down the list, Amazon, Apple, ExxonMobil, like all the oil companies. Even Facebook has massive data centers that they're spending tens of billions and approaching hundreds of billions on a year. These all require real world moving atoms and moving physical things, not just digital. So
I mean, I always I'm very blown away by, like when you're raising capital for something like Millie, you talk to healthcare investors, they totally get it. You talk to consumer investors, and they kind of get it, but they're sort of like, oh, healthcare is confusing. Like, so, but there's enough that are like sort of crossover. And then you talk to tech investors and like, you spend tons of money, like building some companies that have kind of gone nowhere, but I think there's just, people have comfort in different things that they have done before and they know how to do and things like that. So I do think, when you think about building something like Millie, you have to think about your cap table, and that cap table build out does include, sort of people who understand technology-enabled services, businesses, people who understand consumer and brand and experience, people who understand kind of like the state of women's anything in the country and want to do something about it. And then people who understand healthcare. Like, I think you sort of have to build a little bit more of a, a syndicate, which balances those variables out, versus you just kind of go to like your typical Silicon Valley, Sand Hill Road VC, and
you just show up and they're like, "What's the LTV? What's the TAM?"
Yeah, it's
like
a little
who else is investing?
Yeah, exactly. So it's a different conversation with different investors. But I think the biggest thing I would sort of like leave people with is, do not be afraid of healthcare, and do not be afraid of things that have walls. Healthcare is massive. There's lots of room to innovate. You just have to pick the right spots, and the walls can be on wheels. The walls, can be on, and they don't have to be on high street retail with massive CapEx build outs.
And they also don't have to be closed walls. There can be internet connections going out through the walls to bring people in.
Yes,
inside the walls at some point
too. So it can be sort of a combination where it's like, the walls extend to the home. Like, we do home visits. We do 50% of the care outside, virtually, literally. It's, we're kind of a virtual care meets like sort of like in-person care, but we have built a format, which is extremely efficient to do what we do.
Yeah. Well, this is an amazing conversation. Thank you so much for coming on.
Yeah, no, fun to do it. And thanks for coming out to San Francisco to do it in person.
Yeah, it's always fun. And I hope you had fun. If you want to support the show, share this episode with someone building something that touches healthcare. If you don't want to miss future episodes, subscribe to my newsletter in the show notes and you'll get new ones plus transcripts in your inbox every week. Thanks again to Anu for coming on and to Atio for supporting the show. Thanks for listening. See you next time.
Hey everyone, Eric here. At Turpentine, we're building the first media outlet for tech people by tech people. We're the network behind the show you're listening to right now. We have a slate of hit shows across a range of topics and industries, from our AI and investing cluster of podcasts to shows that drive the conversation in tech with the most interesting thinkers, founders, investors, and influencers, like Econ 102 with Noah Smith. We're launching new shows every week, and we're looking for industry-leading sponsors. If you think that might be you and your company, email me at ericaturpentine.co. That's ERIK at turpentine.co, and let's partner together.